Welcome to Broad Eye, the podcast that explores knowledge gaps in ophthalmology and eye care.
Welcome everyone. Here's another episode of the Broad Eye podcast. Today we have Helen Dimaras. She's a PhD, super accomplished. She's involved in research for retinoblastoma in the Sick Kids Hospital in Toronto, also affiliated with the Ophthalmology Department of University of Toronto. So I'll let her continue and to introduce herself. How's it going, Ellen? It's a great pleasure to have you here.
Thank you for having me. I'm very excited to be here. Congratulations on the podcast. A little bit about me. I'm a scientist at the Hospital for Sick Children and an associate professor at the University of Toronto. My interest in retinoblastoma, or childhood eye cancer, which is what my lab focuses on, started when I did my PhD in molecular genetics a long time ago, and that got me learning about cancer as a disease of the genome. And then I moved more into sort of clinical research and global health in my postdoctoral fellowship, which leads me to what I do now in patient engagement in research, a long way off from lab-based research, more focused on patient values and what they like, and it's kind of exciting.
That's very interesting. Before we kind of dive into the research that you do, maybe you can just talk a little bit about retinoblastoma, like to put the topic into perspective. It is pretty rare, right? I used to work with retinoblastoma myself, and most people were kind of like, what? Can you get cancer in the eye? They really had no idea that there was a possibility. So how rare it is in Canada? How often do you see it?
Yeah, that's a good question. I still get it all the time. In Canada, each year, there's about 25 new cases across the country. So that's pretty small. Worldwide, the incidence is one case for every 16,000 children that are born. Essentially, it means that where there's high populations and high birth rates, there will be more children and consequently more childhood cancers like retinoblastoma. In Canada, we have a small population, relatively speaking, and low birth rate, and so we get a small number.
Yeah, and it's funny because when you think about the number, right, 25 cases or so, it sounds small, right? But a small number, but it's a patient with retinoblastoma. It's not like a cataract patient, right, that you do the surgery and the patient's gone, right? Those patients require like many months or years of treatment, many different kinds of treatment and a lot of personnel as well, medical or not, right? So it's time consuming, to treat those 25 cases a year, isn't it?
You're right. It takes a lot of effort right up front when these kids are diagnosed, with the number of visits pretty much every month when they're first diagnosed, if it's a complex case. And actually, about half of the cases have lifelong consequences. Half of the cases have what's known as a heritable form. So the gene that causes the cancer in the eye is broken, or there's a mutation in all the cells of the body, which actually makes it a cancer predisposition syndrome. So these people may get cancers, second cancers, other cancers later in life. So it's a lifelong thing. It can affect multiple generations, and that's why even 25 cases per year, they don't go away. They stay part of the retinoblastoma community for their whole lives. And so it's quite a big community overall.
And how can a patient know that kid might have a tumor in the eyes, right? Because it's not something as visible as a skin cancer.
Yeah, it's something that some people might miss because the child otherwise isn't complaining. There's no pain. Often it's not even a vision thing that parents notice. It's a white pupil. So often this is seen in photographs. You know, when you take a photo of someone and you get that annoying red reflex and you have all these great features on your phone to turn it off. Well, instead of a red reflex, you might get a white reflex. It looks like a cat's eye. It's a shine. And when you see that over and over again, a lot of parents, that's what they first notice and say there's something wrong. They start Googling and they might learn about retinoblastoma that way. Less commonly, it might also be a crossed eye or a red or swollen eye. These sometimes also indicate retinoblastoma. All of these signs actually could even indicate other eye problems. So the recommendation is that if you notice white people, crossed eye or red swollen eyes in a child, just take them to an eye doctor, because even if it's not cancer, it could be something else that could threaten vision.
Yeah, that's the very important point, right? Like, so the retinoblastoma numbers might be small, but there are other things that could look like retinoblastoma, and they are not as rare as retinoblastoma, and they do require diagnosis and intervention as well.
Yeah, yeah, exactly.
And for parents that are a bit more proactive, not to say scared, and would be willing to examine their kids anyway, even there are no symptoms at all. So consider that the incidence is it's quite small, like it's still a rare disease. Is there any indication like to examine kids like no matter what? And if so, how soon would they receive their first retinal exam?
That's a good point. So the unfortunate situation is that there are recommendations for children's eye exams, but they're not uniform. So that means that a lot of different professional bodies have recommendations for child vision screening that are slightly different from each other. So for example, the Canadian Association of Optometrists, they recommend that infants and toddlers do their first eye examination between ages of 6 and 9 months. And then that preschool children undergo one eye exam between 2 and 5 years. Whereas the Canadian Pediatric Society says screening should be as early as 0 to 3 months, and then again at 6 to 9 months. So, I mean, these are all good, and they're within the time you might expect retinoblastoma to be developing or any other vision problem. The problem is that we don't quite have a consensus, and when you study health practitioners and whether or not they're following these recommendations, they're not often applied consistently. So, you really need the parents to push and say, yeah, I want my baby's eyes examined. And then the additional complex thing with retinoblastoma is that because these tumors sometimes are small when they're first developing, even if an eye exam is done at the appropriate time, you still could miss it. And so it's not clear to what extent screening is relevant in picking up retinoblastoma early. It could, but it could also be a normal eye exam and the retinoblastoma is seen later because simply the tumor gets larger and is more visible. So a lot of what we see in retinoblastoma diagnosis is the parent seeing something at home and bringing that to the attention of an eye doctor. And in fact, around the world, for retinoblastoma early detection, most efforts are focused on public awareness of retinoblastoma and making parents aware that if they do notice that white people, they should bring it to the attention of the doctor versus medical focused screening programs to pick up essentially a needle in a haystack, which retinoblastoma is.
Yeah, that's very interesting and important, like to highlight like how crucial it is for the parents to be involved and aware like, of the early symptoms of retinoblastoma. So like for the unfortunate cases that happen to have one, what parents can expect, like in terms of treatment, like they hear the word cancer and of course right away they freak out. So the usual questions are like, is it a life-threatening disease? And the second one, if you save the kid's life, can you save their vision, or is it guaranteed that they're going to be blind on their affected eye for life?
Yeah, it's tough because the eye is so, sensitive and important to quality of life. And, sometimes the truth is saving the child's life comes at the expense of vision. But we're getting better at saving lives and vision together, at least here in Canada and in the Western world. So when the disease is caught early and the tumors are relatively small, there's a variety of treatments that can save the eye and vision. Sometimes that's chemotherapy alongside focal therapies like laser or cryotherapy, which is a freezing beam. There's new innovations now where chemotherapy can be applied directly to the eye as well. So that's a new mode of treatment that would save the eye and also limit potentially side effects associated with chemotherapy that would be given through a systemic way that would affect the whole body. And sometimes though the tumors are larger and they threaten to escape the eye and threaten the life of the child. And so in that case, the clinicians may elect to remove the eye. But even that, the other eye, if it has good vision, survivors report that that's not a huge effect on their quality of life. They adapt with monocular vision. And now prosthetic eyes are quite good matches to the remaining eye so that it doesn't have a huge effect on the cosmetic appearance. And so there's, a good life after that, even with one eye. We're very lucky here in Canada. So you asked, what is this, can you survive it? And our survival rate in Canada is 96%, so near 100. That's one of the highest in the world. And it's really to do with early detection, availability of quality care. When you go around the world, that changes because of varying levels of access to care and awareness of those early signs of retinoblastoma. And so survival can be quite low in other settings.
Yeah, I think retinoblastoma is a great example of a cancer that can be impacted by proper medical care. Right? It's not one of those cancers that, even with the treatment, the patient's prognosis is very poor. This one is clear night and day. If there is proper care, the survival rates are very high, but otherwise they're very low.
Yeah, you're right. I remember an oncologist at Sick Kids. She's retired now, but she was giving the diagnosis to a family, and she said, if you have to have cancer, retinoblastoma is probably the best cancer to have because we can save lives, we can save vision in most cases. And so although nobody wants cancer, if you have to have cancer, this is one that you want to have compared to the rest.
Yeah, that's a good way of putting it. So as we started to talk about counseling, of course, that's it's super important when dealing with patients with cancer, particularly retinoblastoma. Those patients, they're invariably kids, they eventually age, right? And as you said, it's a lifelong relationship that the medical team establish with the patients, and eventually they might want to have kids of their own. And you also mentioned that it is a genetic inherited disease. So what kind of counseling is given to those patients? Are they encouraged to have kids, or are they advised against? Can they be tested to see if their kids will have cancer as well or not? So how does it work?
Yeah, there's been huge advances in genetic testing. So oftentimes kids with retinoblastoma are the first ones in their family. But as I mentioned, about half of them will carry this causative mutation, or the mutation that gives rise to the eye tumor in all the cells of their body. So they have risk of second cancers later in life and also passing on that to their children. And so the genetic testing performed on the child, that result is something that remains part of that child's chart. And when they come of childbearing age, they can book another genetic counseling appointment to learn more clearly their risks. Because of course, when all this is being uncovered as the child is an infant, the information goes to the parents. The genetic counseling is explained to the parents. And so we do have a little bit more work to do to build that legacy of knowledge transfer to the kids as they grow older. And I think that's a big issue in pediatric oncology overall, and we're learning of better ways to do that. But if all goes well, the genetic counseling has been retained by the parents. The child, as they get older, they continue to meet with their genetic counselor and oncologist, and then they want to start a family, so they can really sit down and think about their options. And the knowledge of the of their own genetic result is useful. Depending on their choice, they can do pre-implantation genetic diagnosis, so they can choose to basically undergo in vitro fertilization and select embryos that do not carry their mutation and have a child that will not be affected by retinoblastoma. That's one option. Another option is to go ahead with the pregnancy and know that there's a 50% risk of their child having retinoblastoma, and at the appropriate time during the pregnancy, doing prenatal diagnosis and seeing if the fetus carries the mutation of the parent that was affected with retinoblastoma. And if the infant does, then that child can be born early, so induced just still at term, but slightly early, so near term. And the eyes can be examined right away and keep on being examined until a tumor is detected. And we've actually shown that children that undergo prenatal diagnosis in this way and are pretty much examined from the day of birth onwards have better visual outcomes. In fact, there's one case where the tumor was found so early with special imaging equipment we have now that basically it was treated with just a few 5 laser burns, and that was it. And so that causes minimal disruption to the retina and offers a very good chance for vision for that child as they grow older.
Yeah, it's again, it's very interesting, right? That a kid that it's presumably at a higher risk might at the end have a better prognosis than a kid with a lower risk because he was surveyed more closely and consequently treated earlier as well, right?
It's a very good point. Yeah, knowledge of that genetic predisposition can help with that early intervention. So as more survivors, grow up and come of childbearing age and have kids of their own, we may manage this a lot better for those kids than the ones that we pick up randomly. Yeah.
Very cool. So diving specifically on the project you're involved on, which is super interesting, I'm very curious about. I've been involved in research as well, and traditionally research is basically done by doctors on patients, right? So the role that the patients take on a research project, it's usually as they receive as subjects, right? So they receive the treatment, and they not have much of a say on designing or eventually implementing the findings of the research project itself. And it seems that you're turning that upside down, and you're recruiting patients to actually become researchers. And I want to know everything about it, so I'll let you go.
Yeah, it's kind of a novel idea, and it's actually been happening in the retinoblastoma community for a while. Maybe not to the extent that it's happening now, but definitely there's been a close partnership of survivors and parents with the clinician and researcher teams in Canada. And one example of that is the clinical care guidelines, which were published in 2009. It was the clinicians who treat retinoblastoma and study retinoblastoma across Canada came together with support of the Canadian Retinoblastoma Society, which is an advocacy organization of families affected by retinoblastoma. And together they developed the first clinical recommendations for how retinoblastoma should be treated across Canada. And so that involved patients really as people reading papers, understanding and making those recommendations together with the clinicians. And there's been various other sort of one-off things that have happened because of clinicians and researchers who recognized there was value in listening to patients, but it was never quite formalized. I remember when I was a grad student studying retinoblastoma in the lab, one summer, one of our summer students actually was a survivor of retinoblastoma. She had an interest and was a science student and came and worked with us in the lab. And so that was my first time working with technically a patient or a survivor in a research setting. Of course, she also was a researcher because of her training. And then later on, I became a little bit closer with individuals from World Eye Cancer Hope, which is a global retinoblastoma advocacy organization. And in chatting with Abby White, who's a survivor of retinoblastoma and familial retinoblastoma, her dad was also affected. She would often sort of say, hey, why aren't you studying this? Or would this make a good research idea? And one of my early studies in my own independent lab was looking at how parents cope with retinoblastoma. It was a research that I had no expertise in. I'm not a psychosocial researcher, but I thought, survivors want us to study this. Let's just see if we could do it. And it was that experience and this sort of knowledge that patients really want to be part of and influence research that culminated in us forming a research advisory board with patients. And it was supported by the Canadian Institute of Health Research, so our federal funding agency here in Canada, which started a strategy for patient-oriented research and offered grants to help projects like these formalize and get off the ground. And so we took our experience of this informal relationship with patient communities and advocacy groups and formalized it with this grant and said, we want to run a patient engagement strategy that's going to find patients beyond just sort of our informal network. So really go across Canada and find individuals we may have lost out of the community and get them engaged again. We want to share with them research findings because they might need to know, for example, the new stuff about prenatal genetics and the fact that you can diagnose a baby before they're born. That might be relevant to a survivor who maybe has lost touch with the retinoblastoma community. And then the third one is we want to actually create a mechanism by which patients can influence the research agenda. So we get all their diverse perspectives informing the work we do. And excuse me, as we mentioned, the CIHR actually wants us to do that because they recognize that when patients are involved in research, the research that comes out of the studies is more likely to be adopted and used and lead to bigger patient impact. So that's our tax dollars at work. They're recognizing they want a bigger bang for their buck. And so how better to make sure that our research dollars are making an impact than by making sure the research is including the patient perspective. So that's how it started.
Yeah, it's so obvious, right? Like, I mean, that it's amazing that like no one had thought about that before. Like, I mean, from taking kind of like a business look at it, like if the patients are seen as clients, right, and we are seen as service providers, like what you're doing is basically listen to your clients. Like, I mean, and then research being the product, like you're catering. You're tailoring your product, which is the research is specific to what the patients are telling you that they need,
That's exactly right. It's what any business would do. It's how these focus groups and ad agencies work to sell their products to their client base. And we've been sitting in our research silos thinking that we're the geniuses doing the research that's going to matter, but we're forgetting about our research can't stay just in our scientific journals. It needs to be used and applied, and we can't do that without all the stakeholders on board right from the beginning.
So what started as a passive approach first, right, with the patients were asking to be involved on it.
Yeah.
Now it's more like an active approach. So
Right.
you're out there trying to recruit people to be involved to a varying extent, right? So I mean, people can be just respond a survey, or they can actually be like hired as a researcher. So there's different ways of participating.
Exactly right. Like in the informal approach, you really get one type of highly motivated person who has the time and the resources, and it's maybe not reflective of all the perspectives out there. There's busy people from a variety of academic backgrounds, knowledge bases, but their lived experience is important. It's not unlike all our human resources really trying to focus on this equity, diversity, inclusion. So we don't just want diversity in our patient, we want to be inclusive and allow for different roles depending on what everybody wants to do. And so we first studied what our patients wanted, and how they wanted to be involved, and learned about some fears, this perception that research is something so specialized, I have nothing to contribute, so why should I be part of it? And we tried to cater to those things to have a variety of roles. So we have a parent in research role. So this is someone who's hired right in my lab, who provides lived experience on the research that's happening in the lab, but also leading the engagement of others and helping them, understand when we're putting a grant together and we want patient partners, this is how you put a CV together if they're not of a background that would already know that. This is how to read a scientific article. We have patients who volunteer to translate scientific articles into lay language. Some have scientific background themselves, so it's a lot easier. Some don't, and so the parent in research supports them to do that. We've got retinoblastoma survivors who are now university students and, really savvy also in social media. So they use social media to share research results and engage with survivors who are on social media or parents, and maybe recruit that way. And we document interest in the work through a registry, which we're calling the Retinoblastoma Research Community. Our patient said registry sounds too formal. That's a very researchy term. So we're rebranding, we're calling it the Canadian Retinoblastoma Research Community. And essentially interested people can sign up for two types of participation. The first type of participation is really someone who wants to be kept abreast of what's happening. They want to know about the new research related to retinoblastoma, but they're not quite ready to do the work. And then the second tier is people who want to be kept abreast of all the research, but also want to actively participate, whether it be in picking a research question, providing their lived experience, helping to recruit others, leading a working group meeting, giving a talk at a meeting, like a scientific meeting. We've had parents publish papers with us as co-authors. So there's a variety of roles that people can pick. We have a parent like pretty much managing our website, and he's using his web skills to do that. And essentially, we try to tailor the skills of each individual interested in participating with the roles. And when we do that, we're able to, have that robust engagement. And that's really the work done by our parent in research, who's an embedded person in our lab that's able to catalyze all this exciting stuff with the patient community.
That's good leadership, right? Like playing people's strengths and
yeah,
like adding to one another. All right, so just put some names on things there. Like so, you mentioned like this initiative is the Canadian Retinoblastoma Research Group.
Yeah, so I know it gets a little bit confusing. So the advisory board is the Canadian Retinoblastoma Research Advisory Board. The advisory board is led by myself and the parent in research, Ivana Rastevsky, and a steering committee. And each year we meet annually in person, except this year during COVID, but we have an annual meeting where all our membership gets together, and our membership is documented in this registry, which we're now calling it the community. In my research mind, registry makes sense because everybody registers, but it was a term that was alienating a lot of our members. So the Canadian Retinoblastoma Research Community is basically a database of all our members. We meet annually in person and work every month or so online on a variety of projects. And we govern the strategy, these three goals of sharing research results, identifying patients from across Canada from diverse geography and retinoblastoma experiences. And together we co-create research. And one of the first things we did was to decide on what are our top 10 priorities for research. And we followed an established process to collect research project ideas from across Canada, from clinicians, patients, researchers, and rank them based on, in an in-person workshop where we really discussed what was important, why it was important, and came up with our top 10. And that's what we're focusing on, co-creating research, and not just that those research projects happen, but that those research projects include patients on their study team membership.
Yeah, we're gonna list all that in the description of this podcast episode, and also on our website, so the listeners can refer and find you.
Thank you.
So, I mean, it's great, right? So it's specifically, I mean, you sort of mentioned briefly a few of those, but if you can just list the benefits that the research team, traditionally speaking, right, like the doctors and PhDs and whatnot, are seeing by recruiting patients to help.
Yeah, ultimately we get to learn from patients what they want us to research, and it's better for us to have our research results be used. They're more likely to have an impact, and that's really how we measure the significance of our results. How did this get to a real world change, or is it just sitting in a journal somewhere? I think the benefit too is to recognize that patient lived experience is another form of knowledge, or another data source, if you will, that enhances the research output. It's an underutilized form of knowledge, and I think that access to that, and acknowledging that it is knowledge, it's not just an opinion, it's an experiential knowledge and expertise that is often lacking from our research team. So in the same way you would recruit a statistician because you need statistical expertise, having a patient on your research team gives you that lived experience, and it only serves to enhance your research. Another benefit is, sometimes research, it does come from, a research expertise, and the impact maybe is not understood yet by the patient community. And so this Canadian Retinoblastoma Research Advisory Board and its membership, it's an opportunity to communicate research ideas to patients and help them understand and bring them alongside. When we did our top 10 priority setting exercise, it was interesting because a number of research ideas came from patients, and uniquely patients, which what we were getting at, but a number of ideas also came uniquely from researchers that the patients hadn't thought of. And when we came together in that workshop, we're able to discuss the benefits of these ideas. The patients then understood and said, actually, yeah, that is important to us. We just didn't know about it before. And so this is a nice forum to have those kinds of exchanges and bring important issues to the forefront. So I think that's a huge benefit for researchers as well.
Do you know if there's any other like specialty, any other disease that have something similar, or you're the only one doing that in retinoblastoma?
There's so lots. I think we're the first pediatric cancer to do a priority setting exercise in this way. But definitely there's a lot of patient engagement outside Canada too. The UK is a leader in this, and there's a lot of patient engagement in ophthalmology and adult ophthalmology. And so we borrow a lot of their techniques and expertise from there. There's great stuff happening in Europe. And the USA also has the Patient-Centered Outcomes Research Institute, PCORI. There's a lot of great work and patient partnerships coming out of that. Since Canada started the strategy for patient-oriented research, I think it's also served to highlight some of these existing patient-clinician research partnerships happening across the country, and maybe weren't as noticeable before until SPORE, at least if it wasn't in your field, it wasn't noticeable before. So now it's sort of brought together this community where we can learn from each other. Every province has a strategy for patient-oriented research support unit as well. And so these offer support to researchers who want to engage with patients and learn how to start their own networks as well.
That's fantastic. Ellen, I think that's a wrap. Like, I mean, you did great at answering my questions. I now know a lot more about that initiative, but I'm going to continue reading about that. It's something that looks, I wouldn't say promising because it's a reality, but I don't think you're going to stop there. And the benefits from that initiative will be seen, like, I mean, a long way into the future. Any final words before you wrap it up?
Thank you so much for this opportunity. It's always a pleasure to speak about this project, and especially since you have an ophthalmology audience, I'm hoping that people are interested. If people want to join our community and contribute, please get in touch. I think this is exciting, and congratulations on your podcast again. I'm learning from it as well. So thanks a lot.
Thank you, Ellen. Have a good day.
Thanks, you too.
Bye-bye.
Bye.
And that concludes today's episode of the Broad Eye Podcast. If you enjoyed this episode, please be sure to subscribe on your favorite podcast platform. Of course, ratings and reviews are always welcome. And you can certainly share this episode with any of your colleagues or friends who might enjoy it. Thanks for listening.